Everyone, and welcome to the VACFA hosted webinar series. My name is Dr. Benjamin Kagena. I'm the host, together with my colleagues from VACFA, Professor Rutani Mloiwa and Professor Greg Hasse. And this is a webinar series targeted to alumni who have come to the VACFA's vaccinology course that I'll speak to in the next slide. But just to remind you, VACFA is a unit based at the University of Cape Town, which you can see here. And specifically, we are in the Department of Public Health and Family Medicine. So this series of webinars, the first one is today, and then we've got others that will happen on the 29th of April, and then we've got 3 other webinars scheduled for May. So VACFA's annual African Vaccinology course has been ongoing for quite some time, from 2005 to 2020, and it's only because of COVID that we got interrupted and we never did one in 2021, but we're planning to resume hosting this popular course in 2022. So we will post all the details on our website. But these are the aims of our face-to-face annual African Vaccinology course. I'm not going to go into the details, but for the interest of especially the speakers who have kindly agreed to share their expertise during this webinar, most of the alumni that came to this course, these are their areas of work: immunization program managers, researchers and public health professionals, as well as postgraduate and postdoc. I'm sure after they trained, they've moved on into other areas of their career. But what really prompted us to host these webinars is we noted during the application, there were many applicants who had come to the VACFA course in the past and wanted to come again. And we did a quick survey, which was online, to find out whether there is need to do refresher vaccinology training. And the data was quite strong, indicating that refresher vaccinology training is needed. And importantly, even an online version of refresher training would be helpful. And some of the reasons that were mentioned is to stay up to date with the changing field of vaccinology, to refresh and to reinforce some concepts, as well as to do networking among African vaccinologists. And that is exactly the reason we've hosted this webinar series. And the aims of this webinar series were informed by the data that we collected from the online survey. And this is to provide an up-to-date information on the current and emerging trends in vaccinology, refresh on some key vaccinology concepts, as well as provide a forum for networking among the annual African Vaccinology course alumni. So today, I'm very pleased to say that we've got a very distinguished list of speakers, and I'm going to request each of the speakers to just spend a minute or two to introduce themselves. But the format is that we've got 4 speakers, with the last speaker, Helen Rees, giving a high-level overview of immunization status in Africa. And then we're going to have a 50-minute moderated session by Naveen Taka. And even Naveen, the moderator, please take 1 or 2 minutes to introduce yourself. And then afterwards, after 2.5 hours, we're going to close the webinar. So without any delay, I welcome you, the participant, and thank you so much to our speakers and the moderator. And it's up to, I'll hand over to Daniel, just to a short introduction, switch your camera on if you can, and carry on with the first talk.
Yeah, thanks.
Thank you, and over to you.
No, thanks a lot. Maybe I will not be able, because I'm at the airport now, so it may be very difficult with the noise, background noise. I think you can hear background noise. So my name is Daniel Ngemera. I'm the Senior Immunization Specialist with the UNICEF regional office in the Middle East and in North Africa. Actually, my area of focus is mostly of the countries in the Middle East and some few countries in the north part of Africa. But I'm happy to join you to share my experience on the work which we do. My major areas of focus is on supporting immunization as a whole, as a team lead for the regional UNICEF regional office, and then also to provide support to countries. And currently, most of work which is keeping us busy is also COVID-19 vaccine rollout in the region, which is taking us most of our time. Yes, thanks a lot. Over to you, Benjamin.
Okay. Thanks, Daniel. So if that is the case, so I'm going to say that then Marie can give a talk, and just to mention that we have a question and answer session that I said is going to be moderated by Naveen. So please write your question to the presenters, and feel free also to raise your hand and jump in if you have a comment. We're going to give you the right to speak and switch on your video and share your experience. And in case you've got any problem with audio, please send a chat directly to Nena or to Salim, and they're going to see how they can help you. Back to you. So back to you, Marie. Do you want to go first on your talk?
Thank you, Benjamin. Thank you. Good afternoon, all of you. My name is Marie Rosette Naimana. I am working in Rwanda in the WHO country office, and I am the focal person for immunization program. So we support the government, the Ministry of Health, for planning, implementation, monitoring, and evaluation of immunization activities. And this has come also to include COVID-19 vaccination. That's what I can say right now for my presentation. Thank you. And I am happy, I am really happy to have this privilege to share the experience with colleagues on this platform. Thank you, over.
Okay, so I see Dr. Morena has just joined us. Morena, welcome and thank you for your time. Do you want to have a quick introduction and before the talk? Go ahead, Morena.
Thank you, Benjamin, and apologies for joining slightly late. I was just having some technical issues. I'm Morana Makwana. I'm the Chief Executive Officer of BioVac. I'm a medical doctor by qualification, but I haven't touched a patient in 14 years now because I've been more since I joined BioVac, and you'll learn a little bit more about our dream that was there from day one of establishing vaccine manufacture, and we're slowly realizing our dream, but we'll talk more about that later. Thanks, Benjamin.
Thanks, Morena. Over to you, Prof. Helen. Professor Helen Rees, the floor is yours. Oh, I think we lost her. So I'm sure she'll come back. Daniel, do you want to start your presentation so that we can get on with the program?
Can you hear me? Hello?
Yes, yes, I can hear you. I can hear you, Daniel.
It's me, Paul.
Daniel,
Yeah.
are you able to project your slides, Daniel?
Yes, definitely. I don't know if you can see them now.
I can see them. You can now put it on the presentation mode, and then we should be good to go.
Is it okay now?
It is okay, yes.
No, thanks a lot. I think for me, what I will talk about, I hope most of the colleagues, this may be familiar to you, may not be familiar, because not necessarily, depending on the areas where we are working, especially what's important is to look at where we are now, where we're heading, and then also the weather is changing, starting from the Global Vaccine Action Plan, and then now with the new the Immunization Agenda 2030, which I think at the time of development when we were hit by COVID. So definitely everything has changed based on the new context. But I think it will be good to refresh ourselves to have a better understanding of the Immunization Agenda 2030, given the fact that we are all working at different levels. So it's really important to understand that. And then the other segment of my presentation will be mainly drawing from the WHO UNICEF coverage estimate of 2020, because this is what I put as the official data. To make a big comparison, to look at where we are in Africa, I think the context in the numbers in Africa, I hope some of the presenters will go into more of the specifics. But for me, I think for me covering a few countries in Africa, I may have a different perspective on what my opinion will be in terms of what do we see as a current situation and where we are heading. So I think one of the key important things is to look at the vision where we want to see the immunization going in the current decade up to 2030, is where a world where everyone everywhere at every age fully benefits from vaccines for good health and well-being. So I think one of the good example which we needed to take is, why are we still having a lot of zero-dose children, a lot of unvaccinated children? And this is a key strategy. The vision, I think, is something which will keep us focused. Are we reaching everywhere? Are we reaching everyone? I think that's the key important. And then when we talk about at every age, I think this is something which reminds us, like with the COVID-19, it's no longer about the infants vaccination, but it's more longer about different age according to the risk ratio and what is being defined as a group which should benefit from these vaccines. And I was looking at the numbers of vaccinations for COVID-19. I think when you look in Africa, it's really a big wake-up call for all of us. Why are we being left behind? If you see, some countries have really reached out to almost 100% of their population with more than with the second dose, or sometimes others have gone for booster dose. So why are we lagging behind in most of the countries in Africa, and what should be done? Similarly, for also routine infants vaccination, still we are lagging behind a lot. And so the impact goals, I think mainly of the immunization agenda, is to reduce the mortality and morbidity from vaccine preventable disease for everyone throughout the life course, and leave no one behind by increasing equitable access and use of new and existing vaccines, and then ensure good health and well-being for everyone by strengthening immunization within primary healthcare and contribute to universal health coverage and sustainable development. I think this is a key important point. You know, what we sometimes we say, I think for us, we need really to be clear on that, is we talk about immunization being the victim of its own success. Are we really doing enough? Is immunization still getting enough attention? And what we are doing, we should be doing differently when we talk about immunization agenda 2030. is EPI still be seen as a vertical program all the time, or we need to have different strategies? Are there lessons which we are learning from COVID-19 which can help us to reshape the way we deliver services, especially among the national immunization programs in Africa, in most of the countries in Africa? I think that should be one of the key questions of what we want to see changes happening. And then the vision, and then on the path to goal, I think this is it's just trying to zoom in more on what we're looking at for each of the categories. I think the issues of the full benefit from vaccines, I think is something which is really, really important. And as you know, most of our countries, we are being left behind because the vaccines, once they're made available, the vaccine which is starting today in the USA, in the UK, it may take ages to reach to most of those population who needs most in most of our countries. And what can we do to bridge that gap? I think that's the key point which I wanted to emphasize, even though I didn't include in most of my slide, but I think it's key important point for us to take note of that. How can national immunization programs in most of the countries in Africa make sure that the vaccines, which can make a very big difference, can benefit from most of the at-risk population? How can they be made available within a short time once they are made available from the manufacturers? Once these have been confirmed, how do we make sure that they are reaching to everybody? So there must be a lot of factors which we need to consider, and all these critical bottlenecks which needs to be really sorted out. And I think this is more looking at the strategies, starting from, I think the emphasis is immunization program for primary health care and universal health coverage. I think some of you, if you are API program manager, what time do you collaborate with your primary health care colleagues? Are you all operating under primary health care? Do you make sure that in every primary health care centers or the health facilities are providing immunization services? I think this is what important thing. And I think like the issues, when you look at these key strategic priorities, I think it's really, really important. I think for me, I would look at mainly at the coverage and the equity, which are more important. There is the issue of commitment and the demand, and outbreaks and emergencies. These are still critical. We still have a lot of emergencies. I've seen it, I think in some of the presentation, they will be discussing about the outbreak, for example, the polio outbreak, which happened in Malawi and some other countries which are still experiencing outbreaks. So there is a lot of unfinished business which we need really to tackle. And how do we work together with primary healthcare? Or we need to continue doing business as usual and expecting different results. And I think the core principles, the country, what I would emphasize, the country ownership. This is what is being emphasized. And if you look at, if the countries, there is high level of political engagement, why, despite the fact that now vaccines are available everywhere, I take an example of COVID-19, why we are still behind in most of the countries. I would have projected the slide, especially on COVID-19, but you can see some of the slide I will show is indicating about the numbers, which is showing that in the Africa region, I think we have big numbers compared to other regions, and country ownership is very critical. And then also the issues of being guided by data. I think one of the challenges I'm seeing nowadays is how do we use data for evidence, for reaching out to the unvaccinated children, and the capacity. We are talking about primary health care. I think the capacity of the service providers at service entry point, how currently the people providing vaccination services, the health workers, the vaccinators, how are they empowered to use the data for action? Because in most cases in the past, for me, when I used to work at a district level, we used to emphasize on the need for the health facility knowing their catchment areas, knowing their population, ensuring that the children who have missed out are tracked and traced. Is this still happening a lot now, or there are still a lot of work which needs to be done? I think that's why we are emphasizing also on the need for a stronger emphasis on operating within the primary healthcare framework. And I think I will go briefly. I think I will, on these strategic priority areas, I will talk briefly on these areas. And I think one of the issues in terms of the immunization program for in primary healthcare, in primary healthcare and universal coverage, I think this is as just reminders of what is really important. And having a resilient immunization services which are accessible to all people as an essential part of primary healthcare. And I think this is really, really important. In most of the I think the COVID-19 pandemic has revealed that a stronger primary healthcare, stronger systems can actually get out of the shock easily. And similarly, also in areas where you have a very strong primary healthcare system, it's more likely that you can be able to reach out to most of the children, ensuring that they are vaccinated. So I think there are different key areas which I would like to emphasize on the key focus areas where we are looking at. I think there is the issue of leadership, governance, and management. That's what I needed to really emphasize a lot, and the health workforce. I think what's really important as the national API programs, these are the key areas which are really, really very important at all levels. When we look at the leadership, the capacity within the ministry, the national API program, at provincial, regional, and the district level, I think I can't emphasize it anymore. And I think there is the other area which, if we want to ensure that there is an effective outbreak response, the vaccine preventable disease surveillance is very critical. But I think it cannot continue working in isolation as a standalone surveillance. Definitely there will be a need for considering a very strong way of integrating the surveillance within existing. If there are integrated disease surveillance, definitely that is an area which needs to be emphasized. I think it's something which we need to be re-emphasizing more. And then also the health information management systems. I think these are an area which is also very, very critical. I think from my previous slide, I mentioned about the use of data for action. Without evidence, we don't have right really to be able to convince anybody that we can make a difference. And I think the other area, commitment and demand, is also very, very important. I think this looks at the issue of public trust and confidence. For example, I will go into the key focus area, which I'm seeing as very, very critical, the public trust and confidence, and also public knowledge and understanding. I think you all, some of you are participating, you are supporting maybe COVID-19 vaccine rollout in the region or in your countries. I think you will see clearly that now the vaccines are available, the supply is no longer an issue, but the demand is still remaining a challenge. But I think there are different factors. Also another point, important thing is, even with the children, how do caregivers are empowered to be able to demand for the services? Do they trust into the services? Why are we still missing children, even in areas where the access to the healthcare services is not a major issue? So I think it would be really important when the National API program are doing reviews to re-examine in these areas to look at what exactly need to be there, can be done differently. And I think the issue of coverage and equity is very, very important. Especially, I saw one of the topics we'll be looking at 0 dose, so I will not go in, I will not speak in the details, but I think one of the most important thing is how are we identifying the disadvantaged populations? How are we addressing their barriers to vaccinations? And the most important thing is how are we tailoring the interventions to suit the context? That means the context-specific intervention. I think this is one of the key areas which is really important. Everybody needs to take that into consideration as well. And I think I will not go into the details here, but here when we look at live cause immunization, I think with the COVID-19, it has been a wake-up call for all of us. When we look at immunization, you don't look at only at infancy stages among children and women, but we look at across life course, because more likely some of the disease there is started as an pandemic. Maybe if they become endemic, they will require prolonged vaccinations, and we need all to be well prepared. That maybe with the time, we might need a very strong focus also on other age groups than ever before. So the other point, I think, the outbreak and emergencies. I think currently what we are seeing in terms of preparedness for the emergencies, this is an area which we need to keep on emphasizing more and more, especially with the pandemic, but also with the other, you know, what happened in the past, especially around 2019, 2020, we are start seeing in some countries actually the measles emerging very strongly compared to the previous years. We don't know whether it was because of the disrupted surveillance. And I think what I would add to the national API program is actually to examine the current surveillance system and make sure that if you identify any gaps, I think they are addressed, because definitely there was a lot of focus on COVID-19 pandemic, and then also with the vaccine rollout, all of these could have made some disruption into the routine surveillance, and therefore timely prediction or identification of these diseases may not have happened. And I think the issue of supply is very important. I think one of the challenges which we are seeing is timely availability of the vaccines at different levels. I think the issues of timely forecasting and the procurement of these vaccines is very, very important. In some countries, I think one of the challenges which we still have is having most of the supply systems heavily depending on donors. And how does government provide the additional resources to support? To support the country. I think you can see one of the objectives of the immunization agenda is to increase immunization expenditures from domestic resources. I think that's one of the important and also transitioning away. So a good proper projection. Immunization Agenda 2030 actually is linked to sustainable development goals. How many governments, how many national API programs by 2030, there will be at least 95% self-sufficient using domestic or government resources to finance vaccine procurement and to finance cold chain and others. Are we ready for that? I think this is a key questions as members of alumni, as members of National API program, you need to be asking yourself, and then also challenging everybody to look at what exactly needs to be done to increase the financing from the domestic resources to ensure adequate supply of the vaccines and the system building for immunization supply chain. And I think the research and innovation is one of the critical areas which is very, very important, which we all need to also take it seriously, especially in terms of development of new vaccines and technologies. It's very interesting to see even now in Africa, you are seeing, because of the COVID-19, is considering also local manufacturing of the vaccine, though the technologies is imported, but I think there is a lot of drive for that. I think that requires a lot of research, even if you want to tap into other vaccines as well. So then this decade, I think it could be a very big transformation in how national API programs, they are conducting the business, including heavy engagement into research and innovation as well. With all these different technologies, I think if you look at currently with all the systems, for example, I discussed about supply chain, all of those are really, really important in terms of how we can come out with a very strong innovation. And they will be possible if we invest also in research as well. And I think I'll talk briefly on the framework for planning and the monitoring, and then I think some of the few indicators which is really, really important to understand is looking at the impact score of the Immunization Agenda 2030, and then what exactly it entails. And I think the issues related to future deaths, which have been averted through immunization as part of a strategy for impacting growth for preventing diseases. And then also the number of countries which are achieving in those regional or global vaccine preventable disease control, elimination, and eradication targets. I think, as you can see, we have measles, we have maternal and neonatal tetanus, and then also we have polio. Polio, the target was by 2018, we missed the target. There was a new target 2023, it was missed out. Now the new target, I think, is around 2025 or 2026. So are we confident that we'll be able to control this vaccine-derived polio vaccine-derived polio viruses, which are circulating in some of the countries in Africa, even as of today? And I think the issue of number of zero-dose children is, when we look at when we promote equity, I think it will be related to the reaching out to the zero-dose children. And in each country, I think if we look at in Afro region, currently, you'll see in my next slide, is about maybe 7 point, vaccinated children were about 7.5 or something like that. So are we going to be able to cut these numbers by half, most as it's indicated? I think that is that's what's really important in terms of reach out. And I think that one of the most important thing is, so I think one of the most important thing is for the national API programs to make sure that there is a very, very strong review of the goals, and then develop or revise their national immunization strategies to make sure that it suits the local context as much as you can. I think that's the most important thing. And that's what we need to be doing at this point. And I think one of the most important things here is looking at across the different strategic priority areas, and then also what are the key other indicators. I will not go into the details into this one. So, but what I wanted to check you in this one, I hope some of you have seen it, because this one I took it from the WHO UNICEF coverage estimate. But if you haven't seen it, I would encourage you to, I can send you the link which you can go into the details. Unfortunately, officially, we may have numbers which we are getting from country, but this is unofficial figures. We are all waiting really to see how the numbers in 2021 will look like. But you can see the comparison between 2019 and 2020. I think when we are talking about the impact of COVID-19 to routine immunization or to immunization delivered as per se, we can see in some countries the numbers we are seeing that they were a bit high compared to 2020. Some of the numbers in the other countries are almost the same. But I can see when we have some countries from Africa like Nigeria, DR Congo, and in Ethiopia, who contributes to the majority of these numbers of this number. So you can see, imagine in those 10 countries is when you have the number, the highest number. So I think the key message here is at your level, at the level of national API programs in the countries, how do they dissect more to categorize or to segment the regions and the district? So for easy reach out. And one of the other challenges which we see, because today, if I look at these numbers, they may be not making any sense. How do we periodically, on a regular basis, review the progress in terms of immunization performance and ensure that these children are reached out? I think this is a challenge which I needed to put forward to the national API programs to make sure that as you started the new year, you need to already have your target and keep on tracking. Sometimes I get surprised when I go to a country, they say they are planning for intervention to reach out to the missed children, but actually you are reviewing the data of previous year, maybe it is in June 2022, and then you are reviewing the data of 2021. Sometimes it may be good, but if we want to see major changes and to have an effective and a good impact, it's better to have everything from day go. At lower levels, they do reviews on monthly basis. At a national level or at annual level, they do periodically reviews it in the course of the year and make sure that remedial actions are taken immediately because you are guided by the targets. That's what most I think which can make a difference. But I think with the COVID-19, you could see clearly that there was a change in terms of some countries. I think there was a sharp decline in the number, a sharp increase in the numbers. And I think this one is looking at, I think you just take an example here, you see like the African region, like there was some additional increase in the numbers of under-vaccinated in 2020 compared to 2021, where globally the numbers increased very significantly. And I think the majority, the biggest number come from the Afro region. But, all in all, what is, I think when we are seeing here is that the Africa region still contributes to the majority, to the biggest number of those who have not been reached out, the number of children. So how can we change this? And I think, most of the countries, even with the Gavi support, I hope all of you have been working with the Gavi, you can see clearly that the biggest chunk, the biggest number of those who were missed out, I think they came from Gavi countries. You can see, I think in 2020, the number increased significantly globally. The numbers which were the numbers of unvaccinated. For example, if you look at in Gavi countries jumping from 10.6 million going to 13.7 million, so the quite significant of number increased significantly. I think that's what we are seeing with the major impact of the COVID in the region. So I think one of the things which we don't understand is whether which we needed to see more the data of 2021, because the review is going to be in July, is when they will be released. We want to see more whether even with the countries working hard to increase the uptake of COVID-19, whether this could have further contributed to further decline in the routine performance. And I think this is another number on 0 dose. I think I saw there is another presentation which will be looking at 0 dose. And I think you can see clearly that the numbers of 0 dose in the Afro region increased 7.1 to 7.7. It's sometimes a significant increase, almost more than half a million children which were missed out compared to 2019. So that is also something which we needed to be watching closely. And this one is about the introductions of the new vaccines, which is one of the key driver for preventing more vaccine-preventable diseases, which the vaccines are widely available. I think in 2020, you could see a sharp decline. Of course, you can see from different years because of the IPV, for example, introduction, there was a sharp increase. But all in all, what is the key message? As you know, most of our countries in Africa are still low-income countries. You can see the uptake of these new vaccines remain very, very low in low-income countries. And what can be done actually to increase this uptake of these different vaccines as well. So I think this is my last slide, and I will be able to take up questions, maybe a few questions or whatever. I can reach out to leave out my message because I will be traveling in the next few minutes, but I will stay over for a few minutes before that, but I will be happy to answer questions. So thanks, colleagues, and I will be happy to answer any questions. And okay, that's it from my side. Benjamin, over to you.
Thanks, Daniel, for that excellent presentation. I will ask people to send a chat on Q&A, to send their question through the Q&A chat box, so that we can proceed with the next talk that is going to be given by Dr. Murray. Over to you, Dr. Murray.
Thank you, Benjamin. Let me share my screen. Can you see my screen?
Yes, yes, I can. Go ahead, Marie. Thank you.
Thank you, Benjamin. Good morning, good afternoon, everybody. Good morning. We are discussing the challenges and solutions to the zero-dose children in Africa, and we'll talk a little bit on recent polio outbreak which happened in Malawi. As the background for my presentation, as outlined, we are discussing on vaccine in general. Then we will go through vaccination coverage in Africa and worldwide. We look at zero doses and under-immunized children, and we will talk about challenge, solution, but also discuss the recent outbreak of World Polio Virus 1, type 1 in Malawi. As we all know, vaccination is the one of the great cost-effective public health intervention, and this intervention has helped to achieve the eradication of smallpox worldwide. It was eradicated due to immunization. 5 regions out of 6 have been able to eradicate World poliovirus or the types, and we are progressing to the elimination of measles, where 81 countries representing 42% of the total countries have achieved measles elimination. And out of 59 priority countries which were selected for elimination of maternal and neonatal tetanus, 47, which is around 80%, have been able to eliminate maternal and neonatal tetanus. When we look at the data from outbreaks and vaccine distribution, we were able to realize that about 31 million deaths were averted with measles vaccine alone between 2000 and 2020. We are aware all about the recent development and distribution of COVID-19 vaccines, which have been helping to control the spread of COVID-19 pandemic. So vaccination, it's a tool which really helps to control diseases. And we all know that there are other vaccines which have been developed so far. We are aware of malaria vaccine, which is available now, the Ebola vaccine, but also other vaccines which are still under development, and they may come may come out for the use in the coming years. When we look at the history of the vaccination, the EPI were launched in 1974, and at that time it included only 6 antigen, as we can see from the slide. And this it has been developed very quickly. In after 16 years, vaccination was able to protect around 80% of world children from these 6 diseases. But also to extend and reach the EPI and to help the poorest country to introduce new vaccine and used life-saving vaccine. The Global Alliance for Vaccine, which is Gavi, was created to try to help countries to boost the immunization and protect more and more children against the vaccine preventable diseases. For the vaccination coverage in the recent data from 2020, we see that the DPT3 coverage and MCV1 were estimated at 83% and 84% respectively. And the highest coverage was observed in Western Pacific region. This is WHO region where they have a coverage of 95% for both DPT3 and measles containing vaccine, the first dose. African region is the region which is lagging behind, as my colleague Daniel said before, with a coverage for both DPT3 and MCV1 estimated at 72 and 69%. These are the lowest coverage worldwide and are being observed in Africa, which is also having the high dropout rate estimated at 8% in the Africa region. When you look at to the map, you see that Africa is the one region which is still having the coverage, the more countries which have coverage less than 80%. And this is really a big challenge when we are discussing the zero dose and the under-immunized children. Looking at children who are missing vaccination, we can see on this slide that in 2020, we have an estimate of 17 million children who did not complete their vaccination. And around these 17 million, we see that around 65% of these children are located in 10 countries. Among these 10 countries, all the 4 countries are in the African region. We can see from this slide that Africa region is the one which has a big number of zero dose children, representing more than 40%. I think it is around 45% of the total estimate of zero dose children. It has a number of 7.7 million children who are zero dose. Maybe coming back a little bit, when we talk about zero dose children, it is all these children who have been able to get vaccination who get DPT1 vaccination only. It means that they have been vaccinated against tuberculosis, they have received the BCG, then they received the DPT1, but they didn't receive the other series of the vaccine. And considering the economic zone, about more than 90% percent of the children who are zero dose are coming from low and mid-income countries. And as my colleague said again, Gavi eligible countries are representing 80.1%. You see that the challenges we will talk about may include also the capacity of the country in regard to economic and financing. These are the big challenge to the vaccination coverage in the Africa. As I said before, challenges in Africa include political will and leadership, but also the commitment to make vaccination as a high priority. It may be that many African countries are still struggling to advance their development, to develop their infrastructure, but sometimes vaccination is not in some countries as a high priority as it is. So they do not concentrate effort to make vaccination as a high priority. There will be a need really to focus on advocacy, to make political people understand that vaccination may be given a high priority. We have observed that there is also a lack of sustainable resources, including human resources for vaccine and immunization. When we talk about health system, you may find that in some health facility, there are lack of personnel, and there are also lack of infrastructure, which are not enough to support vaccination service delivery. And I think that Daniel has talked about affordability of vaccines, where we found that in a developed country, they develop their vaccines, they use them, and this vaccine will reach our continent maybe some years after. So we are also having issue to access to affordable vaccines. And we, as with the COVID-19 vaccination, we all know that African region has started to think about transferring this knowledge and the technology to African countries so that they can be able to develop their vaccines. Another challenge includes the fragile health system to ensure vaccine delivery, where we will find the inadequate cold chain capacity, inadequate health personnel to deliver vaccines. And this health personnel inadequacy is also observed in both quantity and quality. The number is insufficient, but also the health personnel is not enough trained to deliver vaccines. Daniel has talked about the use of the data. We have been observing the lack of capacity for using data for planning, monitoring, and evaluation of immunization services, where you may find that some health facilities, some health centers don't know their target population. It's really difficult when you are delivering vaccines and you don't know what is your target population. The use of data is still challenging, and there will be a need of focusing in this area as well if we want to reach all these 0 children. And we also have the absence of sustainable intervention to reach hard-to-reach population, including those living in remote area, conflict zones, the most vulnerable, the community which are disadvantaged, and nomadic, refugees, marginalized. There is really an issue to reach all these population. If we go back to the previous slide, you can see that in Africa, we have the DRC, the Democratic Republic of the Congo, we have Nigeria, we have Angola. But coming to these two countries, Nigeria and the Congo, there are many countries in the Africa which are having insecurity. Insecurity is in some countries is one of the biggest challenge to reach children with vaccination. So it is really important that leadership define or identify sustainable intervention to regularly reach these children who are in conflict area settings. And quickly we can go to the solution to this deal or those. This is a kind of, I think that participants will also discuss more on this. We found that there is a need of increase and sustained commitment to make vaccination as a human right for all. That commitment will help the government, will lead the government to make sure that more resources, they are mobilizing more resources from domestic funding to sustain immunization, to increase immunization service capacity to reach every children. This is really very important. When we are analyzing financing data in the Africa, we see that more countries are relying on donors. You may find that about around 80% of the countries, the vaccination services are donor depending. This is something which we need to start thinking how to change this and mobilize more domestic funding to ensure sustainability of immunization services. Strengthening health system is a key, very key strategy to ensure immunization services reach everybody. And this health system need to be strengthened in terms of health workforce, including human resources, increasing infrastructure and the service delivery point, including health facility, health post, health center, outreach strategy, but also increase the capacity in equipment, including cold chain capacity at all levels of the service delivery, so that we can ensure that vaccine supply and distribution is adequate enough to serve the population. There is a need also to promote the use of innovations and data for planning, monitoring, and evaluation of immunization services. What are the innovations? What can be done differently from the country A to country B? What we can learn from other countries, other African countries, which have been able to reach the highest coverage for immunization. And there is really a need of innovations to reach those people in a security zone, those people in a remote area, and those population which are dispersed everywhere, which are nomadic, refugees. There is a need of innovation to reach all these people. Also to reach the 0 dose and under immunized, we can't forget uninterrupted vaccine supply and distribution. One of the key challenges which was highlighted in many studies that was conducted in the African region, they say that many countries face a problem of stock out, which may be due to financial issues, or this capacity of planning, the limited capacity of cold chain, all those are the factors that need to be addressed to ensure that we reach the target of reaching every child with vaccination. We need also to increase and maintain people's demand for immunization services. People need to understand that immunization is the right of everyone, every child, every people, every person. He has the right of accessing to the vaccine. These the people need to understand so that they can demand for immunization. We need to get the community engagement, the community engagement for demand to immunization services. But also we will need to establish, Africa need to establish a strong strategy to increase coverage in hard to reach population. And for the coming 10 years within the immunization agenda, all these issues should be brought to the government, policy makers, so that they own. There is a need of ownership of immunization services, of ownership of the strategy, ownership of the target, so that immunization can be made universal for all the population. We wanted to talk about the world poliovirus type 1 outbreak in Malawi. As we have been following the information, this was declared in February 2022 and have been declared after a case was detected in a young child in the capital of Lilongwe. Yeah, we as Africa, we all know that Africa has been certified to have eradicated all the type of world polio. And this is the first case of world poliovirus in the last 5 years. Africa was declared free of indigenous world polio in August 2020. And the strain detected in Malawi was found to be linked to the one that has been circulating in Pakistan in October 2019. So this means that this strain, this virus is not domestic to the African region. It is an imported case. It means that Africa region will not lose its certificate to have eradicated polio, because this is an imported case. And this is can happen anywhere else, where Afghanistan, which is still having circulating poliovirus, Pakistan, they can always be imported in any country. For the response, the supplementary immunization activity are ongoing to increase the population immunity. And I wanted to let you know that from the declaration of that case, there is no additional case which has been declared from the same country. To this, I would thank you very much for your attention, keeping in mind that immunization saves life. And this is an experience that we have seen with this COVID-19 vaccination, where the COVID vaccine were able and helped to control the pandemic. Thank you very much.
Thank you so much, Dr. Marie. I'm sure there are so many questions that will come during the discussion that is going to be moderated by Dr. Naveen. So let's move on to Dr. Morena, who is going to give us the third talk. Dr. Morena, over to you.
Sorry, I was talking to myself there. Thank you, Benjamin. I will reflect a few slides to take me through the talk, which is to flip towards vaccine manufacture and call it the challenges that come with that. So just give me a moment and just make sure that I do share. Sorry. Make sure I have the right slides opened. Okay, are my slides reflecting?
Yes, all clear, Morena. Thank you. Go ahead.
Okay, thank you very much. Firstly, I'd just like to say thank you for inviting us to this forum. Vaccine manufacture is something that's only become topical, since COVID-19. However, before the pandemic started, it was a very lonely space and a very, ill understood space. I think even now, I don't think people have a full understanding of the breadth of the complexity of vaccine manufacture. So I'll try with the next couple of slides to talk about manufacture. But before I do that, I'm sure we're dealing here with clinicians and people that are on the ground. We often intersect with products on the continent once it comes through in two ways. So the first is through the immunization program, which is obviously the largest program. So that's when we intersect with the product, and whether our governments buy them or they get bought by donors, but we only see them land, and that's sort of like the interface that we have. The second interface that we have with vaccines largely has been through clinical trials. And, the continent, if you segment the area of research in terms of vaccines, it's really heavily leaning towards clinical trials, which is not a problem because we do need the data, and we need to make sure that products work in our settings and make sure that they are effective as well, including the fact that they should be safe. So we do intersect with them also in clinical trial setting. However, outside of that, there's minimal intervention. So how the product gets developed, we have a fairly, we hear about it and we read about it, but we actually don't have any interaction with it because not much of that is happening on the continent. Even the manufacture, people say, okay, where's my vaccine? Where's my vaccine? And they only see it when it lands. So what I'm trying to describe here is that because we're seeing products land as far as programs and concerned, and once it lands, and the fact that we only also interface with them through clinical trials, means that there's a big gap in our knowledge of the whole process around how do we actually develop vaccines to get them to clinical trials, or how do we manufacture them from scratch and to get them to be part of a finished product. So hopefully with this few slides that I'll just give you a flavor of what's happening on the continent, what are the challenges. I think many of them may be known, but maybe I'll just outline that. Yes.
Okay, all right. No, I thought you were moving slides, but we are not seeing them moving on our side. It's
yes,
fine.
No, this is just a preface of that. Thanks, Benjamin. So this is a slide that I often use to describe what happened before. So I think part of my talk is about what was happening before, the past and the present. So this is really, if there's one area of vaccine manufacture that keeps me awake at night, is really about demand for vaccines. And I'm not talking COVID only here. I'm just talking about general to say, where's the demand coming from and who's buying the vaccines? So what you're seeing on the left is really where products get manufactured, and you'll see that the continent in the blue, in terms of the blue shaded areas, there's only one element which is small on the western coast, and that's Senegal. But there's not routine vaccine manufacturing in terms of supplying to Gavi is really not coming from the continent, whereas on the right, it shows where the product is going to. And so the ones that are shaded in blue on the right shows where the product is going to, and the one on the left shows where the product is coming from. So you can see there's a big mismatch in terms of that, whereas you would want the blue to match the blue, or the pale to match the pale, but there's a real mismatch in them. And now again, we'll talk about COVID and what COVID is going to be doing. But essentially, this is a big challenge for a vaccine manufacturer that wants to tap into vaccine manufacturing on the continent. Again, who is supplying mainly our continent? So just to step back, or maybe the slide will come later. So our continent, in terms of the slide that I'm focusing here, is the supplies on the blue. Who is supplying vaccines mainly on the continent? Now, the vaccines are listed there from BCG right up to IPV, but you'll see that on your right is that the manufacturers that are listed there, and I won't go through all of them, essentially it's largely Indian manufacturers, and only one being Institute Pasteur Dakar, which is in a bit of maroon there, was manufacturing yellow fever vaccine, but that was also in single-digit dose, single-digit in terms of millions of doses. So the main message that I'm sure you guys all know is that for routine vaccine manufacture, the continent is not manufacturing routine vaccine. And I'm emphasizing routine vaccine manufacture because COVID looks great, COVID looks sexy, it's the latest game and everybody wants to get into it. But the sustenance of vaccine manufacture is based on routine vaccine manufacture. So the other topics that you guys are talking about, epidemiological wise coverage, are so important, to routine vaccine manufacture. Okay, so let's talk about this manufacture because it's nice, it's one word, or we talk about development and it's all a nice word, but why is it so complex? And why is it that we can't just establish it, just do it, just get on and do it? So on this slide, what we're trying to depict is, it's a simplified slide, and we actually doesn't do justice to maybe what's happened, but just gives you a taste of what is actually, can you hear me? I think I was muted there.
Yes, I can hear you.
Oh, okay, thank you. So when you look at the three areas that are on this slide, the first is R&D. Okay, now this R&D can even be at a university. Okay, but when I talk about R&D here, I'm not even yet talking about clinical trials. I'm talking about lab-based work to say I'm going to develop something from scratch. Now that can happen in an R&D setting in a company or in their labs, or it can even happen at a university. But it's essentially the infrastructure that is required there is non-GMP. And I'm emphasizing GMP because good manufacturing practice is a real, it's not nice to have, it's a must to have, so that we ensure that the products are manufactured in the right framework. But you experiment, you develop your product in that setting. Now, is it expensive, that first block? Absolutely, because research takes time. If you take mRNA vaccines, the guys have been there for 20 years, just trying to develop. So it doesn't mean that it's inexpensive, but it happens in a setting where the infrastructure is not too expensive and the regulatory requirements at that stage are not high. You now start getting towards the clinical setting where you've developed your product, you've had some animal testing, now you're going into humans, and that's where the regulator says, okay, wait, before you get into humans, I need to make sure that not only is your data looking good in terms of the history of where it comes from, but the environment in which you manufacture vaccines doesn't need to be huge, but it needs to be in a setting that I can think as a regulator that it's safe to manufacture. And that's where we start using the word good manufacturing practice. And there are standards which are quite detailed that are required to maintain and uphold good manufacturing practice. You can't label yourself as a GMP until your regulator tells you so. So that's where you really start working with the regulator. Now, I know that a lot of time people think about the regulator in this setting about clinical trials, but the regulator plays quite a few roles, one of which is to look at and make sure that manufacturers are doing what they need to be doing. And that GMP manufacture for clinical trials that goes up to phase 3 can happen in small scale setting. Now, typically the second block is not in a university setting. Okay, and that's where now, costs start creeping up because you need to maintain, you have to have the right people. The guys that are experimenting in the lab are different from the guys that are doing the GMP. So already your facility cost goes up, but your people cost goes up because you need the right people that would get into that. Okay, now let's assume that everything goes well, you go into clinical trials and the product works, you then get into commercial manufacture. Now, why is there a line before? Why have I put a line at just before phase 3? Because typically manufacturers would invest and make sure that the phase 3 clinical trial material comes out of the same facility that would be doing commercial manufacture. So there is an upfront risk that typically manufacturers would take, where they would invest upfront even before the conclusion of phase 3 clinical trials, which means that you're spending already billions of dollars to set up these big, huge factories with the hope that they will pass. Okay. Now, and there are obviously many good examples around how that has been successful, but there are other cases where this hasn't worked out. And just to show you the risk that that companies take. So let's take dengue vaccine. Sanofi, the French multinational, invested in this whole value chain. And when the product went into phase 3, they invested 2 billion euros into a new facility with the hope that that dengue vaccine was going to work, which the phase 3 data seemed to be positive. But when this rollout started, let's call it in a post, call it a phase 4 setting, that's when some of the safety signals started coming out. And this is besides investing in R&D, but there's 2 billion. So there is a big risk that manufacturers do take. And you can see that then the regulatory scrutiny is higher. And why I'm belaboring this point is that people are saying, well, why can't you just manufacture? Why don't you do this? It sounds very simple. That's because, and why it's done like that is because we're only looking at clinical trials and we're only looking at the product landing. Nobody on the, not nobody, but very few people actually understand what it takes to bring a product to market. Only because we see a product land, it lands from India, it lands from the US, it lands from wherever, and we think that it's easily replicable locally. So just moving on then, in terms of my next slide, is that commercial bit. So maybe let me go back up. That last block called commercial manufacture. If I leave it like this, I would have done an injustice because that part is quite complicated. That block called commercial manufacture on the last part of this value chain, actually, if you expand it, it's quite an expanded site. You have, from when you start from your seed lots right up to transportation, and you will hear the term that says drug substance or API production. And in a simplified form, this is the block that I'm referring to in terms of drug substance manufacture. On the continent, this is done minimally, and it's high risk. That's where the IP sits. And the many factors why there isn't capacity at the moment. Doesn't mean that it's not done, but it comes with its own nuances. And then you have the downstream side, which is the drug product, which is the formulation for finish. Now, many of us, and I'll say that, people say, well, you're just doing full finish. Now I must say, and I'm speaking from very many manufacturers, it's actually quite offensive hearing those things because full finish is not easy. For anybody that thinks that it's easy, I'll come to BioVec and I'll unpack what that is. Because manufacturers typically don't share what happens behind the scenes, formulation full finish is not as easy as people make it out to be. It's a tough game, it's expensive. But, the stakes get higher and also the risks get higher, as you get into drug substance manufacture. But I just wanted to just say that commercial piece now, we've spoken about development and the type of infrastructure that you need. But this commercial manufacturing piece is obviously quite huge, and it has its own various components, which we can unpack perhaps if we want to in the Q&A sessions, or else I'll spend the rest of my time just on this slide. I'm just going to make BioVac as a case study, and then I'll zoom out and talk about what's happening on the continent. Now, following the value chain, and I won't spend too much time, but what we've been doing, we've been set up since 2003 to essentially re-establish vaccine manufacture. South Africa used to have vaccine manufacture back in the 60s, 70s, and 80s. All of that ground to a halt, and the revival came through BioVac. And BioVac has been following what we call this reverse integration strategy, starting with packaging and labeling, going to filling and formulation. Now you will see that drug substance piece, the API, is still a piece that BioVac still hasn't yet gotten to, and I'll tell you what we're going to do. But that's not easy. Not that technically it's not easy, but to get towards that point is not that easy. But we've also been investing in product development. We've been very fortunate that we've been working with many logos that you see there that have really given us the confidence, and I guess we've also given us the confidence back that we can manufacture products for Pfizer or Sanofi and others. We work with Cuba, we work with Indonesia, we work with Denmark. We really work with many world-class partners. And this is really in us reviving vaccine manufacture. Product development is key. So BioVac doesn't do research. Okay, we do product development, which means that if a concept has already been determined, we then apply it to a particular antigen. And we've been working with the Gates Foundation on some of our bacterial conjugate vaccines. And lately, we are part of the WHO mRNA hub, which I'll touch on very briefly in my next set of slides. So essentially, the routes to get to drug substance manufacture, you can take two routes. You either develop your own product, okay, and it comes with its own risks. And then once it's successful, you get into drug substance manufacture. Or you start partnerships that can get you from that point. So, and BioVac is looking at both. We are looking at continuously look at product development in the bacterial conjugation space and in mRNA that will get us to drug substance. But on another, we're still looking for deals of already established products that we can do local drug substance manufacture. But essentially, you can see that we're almost there from fulfilling the value chain. The scale may not be that huge for now, but the capability exists. I think that's the main message that I wanted to send. As I say, product development is something that's very close to my heart. People are saying, but you guys are fairly small manufacturer. Why are you dabbling in product development? But until we develop our scientists in terms of being able to do development work, we won't be able to get there, and we'll still be talking about Africa that's just importing vaccines. So we have two examples of a Hib vaccine that we developed, and we ended up out licensing, and that's where we developed our bacterial conjugate vaccine capability. That was extended to a Group B strep vaccine, which we've completed preclinical work in. So we have a separate lab. This is non-GMP, but we have those labs at BioVac and at our location in Cape Town. I just want to touch quickly on COVID-19 because it's quite topical and where BioVac has been involved. So I'm going to outline in the next slides what the mRNA hub is all about, okay? But we are involved in developing mRNA capability through what is called the mRNA hub and spoke model. BioVac is not developing, but will be a recipient of that technology. But that's how we want to participate in terms of COVID-19, but longer than COVID-19 using mRNA as a platform. The second part that we are involved in COVID-19 is that we struck a deal with Pfizer to do local fill finish of their mRNA vaccine, the Pfizer BioNTech vaccine, and we should be commencing towards the end of the year in terms of that fill finish. The tech transfer is underway. We're 60% there, so that's how we're participating in COVID-19. And then the last part is that BioVac is also involved in distribution, so we're distributing on contract via the Department of Health on the Pfizer and J&J vaccine. So we can handle -70 and -20 product. And why I'm emphasizing this whole value chain is really about those people that are thinking about building capability on the continent. people are saying, no, just do research and then you'll be fine. No, just set up the manufacturer, you'll be fine. It's a lot more complex. The whole value chain really needs to be looked at. And where are you going to start? Are you going to start at the end? Are you going to start in the beginning? Are you going to start in the middle? It's the answers are not, the questions may come easy, but the answers don't certainly come easy. Just moving on about the hub, which I think is a very important, and it's not because BioVac is participating in this, but I think it's really something that as Africans, we should be very, very proud of. WHO a year ago looked at, the scarcity of vaccines and says, besides COVAX and Gavi and everybody else trying to get vaccines to the continent, how can we build a sustainable model where vaccines can be developed on the continent, where the continent can be able to respond, and beyond the continent, how can this happen? And so there is the mRNA hub and spoke model, and out of many countries that put their hand up all over the world, South Africa was selected to be the hub. This is coordinated by WHO and the Medicines Patent Pool, and a local company called Afrigen is serving as the hub. So what does it mean by a hub? The hub means that they're working with WHO, Medicines Patent Pool and other partners to develop mRNA technology as a platform, okay? And obviously we need to demonstrate that through a product, okay? And then have recipients. So they will then transfer that knowledge to recipients. Now, BioVac in this slide I'm showing that, okay, because I'm from BioVac, but in actual fact, when you look at BioVac there, think about 12 other spokes. So there are 12 other spokes that have already been announced, quite a few on the continent, Kenya, Senegal, Tunisia, Morocco, at the last count. I'm sure I'm missing some. But there are also hubs in Latin America and India and Indonesia. So we will all be receiving this technology platform from Afrigen, and we will be able to make good use of it and somewhat be able to be in the drug substance manufacture of mRNA. So it's a very important initiative. And obviously under the stewardship of the Africa CDC, the various governments that are involved, and locally from academic support as well through our Medical Research Council. So I'll just run through the next coming slides. I won't go through this. This is about BioVac's infrastructure. Maybe I can skip that. But essentially, I think what is important, and again, I'm just probably saying the same thing in different ways, is that when you look at this whole thing, the capability that we've been able to build is on sterile manufacture, okay? And on which platform? We've looked at bacterial conjugate platform, and we'll be adding mRNA. Cold chain is important because those are the things that are really on the ground. And so we can handle 2 degrees, -20 and -70. Quality control is absolutely important because you can't release a product until it satisfies the right standards. We work with multiple partners, and obviously our mandate is more public sector focused. So it's really setting up vaccine capability is not as easy as it probably sounds when you read an article. It's quite complex. And this is just a case study of how what we've done, but the journey is still much longer. Maybe let's just talk about the future, because this is the last segment in terms of where are things going to. So I'm really, really excited that there's a lot of emphasis and focus on the continent. Doesn't mean that there's no risk, but you will know that, or maybe that there is an aim a year ago, the AU, the African Union, through Africa CDC, established a very big ambition, which is that on the continent by 2040, 60% of vaccines should be manufactured locally. I think I'm very supportive of this, as challenging as it's going to be, but I think we need to put that and get going. And there's a lot of initiatives that are going to try and realize this thing. So this is there. Our governments have said it. They've set the tone, and this is what we need to achieve. But below that, there needs to be action. Now, this is not to say that, okay, manufacturers just go ahead. This is around a multi-organization and a multifaceted or multi-player. It's governments, it's research, it's funders. It's all the role players that need to help in terms of getting towards this. But essentially what I'm saying is that we get given direction now by what needs to happen in terms of getting to 2040. Now, there are hubs that, and this is not about the mRNA hub, this is about manufacturing hubs, and essentially looking at making sure that the continent is covered, that it's not only the likes of South Africa always saying something, but that the East, the West, and the North is all covered. And that's the aim, so that we have geographical spread of vaccine manufacture. And to that end, I mean, a lot of initiatives have been announced. Now, these are just some of them, and I won't go through all of them, but I'm sure you guys have read many, many headlines around vaccine manufacturing capability coming up. So, so all these countries that are there have announced some form of capability in terms of vaccine manufacture, right from the West, taking Senegal, Ghana, Nigeria, to the East, around Egypt, Kenya, and Rwanda. Moderna is going to have said that they're going to set up something in Rwanda. BioNTech are also, Moderna said they're going to set up something in Kenya. BioNTech said they're going to set up something in Rwanda. And South Africa has BioVac dealing with the likes of Pfizer as far as COVID is concerned. Aspen is dealing with J&J. So there's a lot of activity that's going to be there. I think firstly, it's exciting to see so many initiatives. But I want to put a caveat, and this is really just purely based out of experience, that, we can't be setting up vaccine manufacture on the back of one vaccine or one disease target, especially if that is only pandemic. You can't set up vaccine manufacture only for pandemic purposes. So, okay, I know BioVac's plans. BioVac is a beyond COVID-19 player. I'm not sure about the others, and I can't speak for others. And the only signal that we can have, and wherever we have an opportunity, is that don't set up vaccine manufacture for only one product for a pandemic. Have a more sustainable plan, but do go ahead. And yes, maybe utilize COVID-19 to give you the tailwind. Do something, but let that not be your end game. And so I'm hoping that so some of these announcements will see themselves to materializing. So I'm excited on one hand, very, very excited that there's going to be a lot of players. We need a community, we need an ecosystem, we need to be sharing skills. That's what we need to be doing. But on another, we should make sure that these ambitions become very practical, and that we're just not announcing just for the sake of announcing. My last slide is that, or almost last slide, I think, 60% of the demand is coming from Africa. So we know, we can have vaccines here. We need to sell them. We need our governments to buy vaccines. So there is a market to some extent from the volume. We know that the demand is there. The purchasing is something different. But, kids are being born. We need vaccines to come on the continent. We still need to figure out who's going to pay for them, which is a big factor. But it's not that the continent is not without vaccines, and I'm sure that's quite obvious. And again, this is really currently less than 1% of the continent, the manufacture is happening on the continent. We need to utilize we've seen in the impact of COVID being the last to get vaccines. We need more supportive local environments. We need the global community to help us and put pressure on our governments. We need funding, from the likes of World Bank and others. And ultimately, we need to make sure that we use the newest technologies that are coming. There's no point using old technologies. Life is moving on. We need to look at more newer technologies. So with that, maybe this is where I will then end. And obviously, I'm looking forward to the Q&A session. And sorry if I've rushed through some of the slides, but I thought for the sake of time that that maybe I can pick up on the Q&A side, Benjamin.
Thank you so much, Morena, for that excellent talk. I'm sure there will be some questions that will be asked and some discussion point during the Q&A session. Thank you so much. Let's move on to Prof. Helen Rees. Helen, please introduce yourself and carry on with your 10-minute high-level talk, overview about immunization status on the continent. Over to you.
Thank you, Benjamin, very much. I wonder if the host could start my video. I'm apparently blocked on the video.
Okay, Salim and Chantal, will you please assist Prof. Helen Rees?
So I'll start in the meantime, because I know we're pushed for time. And as soon as I can start it, there we are. Lovely. Thank you very much. So I've been asked just to make some sort of what were called high-level comments about lessons learned from COVID for the African region. And I've got 10 points that I'm going to quickly go through and to see what sort of lessons we should be now thinking about. Morena and other colleagues have mentioned some of them. But let me start with the first sort of lesson learned for our region. And I think it's a lesson that we've got to think about in the context of the global financial stresses that are going on. And that is that what we saw during COVID was nationalism around vaccines, nationalism around therapeutics. What we've also got that's been going on, as we saw from that lovely slide for many years, are global philanthropic organizations such as Gavi, which has a huge amount of international donor funding, and which has really changed the face of vaccination. So I think that one of the first sort of lessons learned, and one of the things I think we're going to have to think about is, as we move forward, is how much support are we going to continue to get from global philanthropy. We hope that Gavi will continue for a long time to come. COVAX initially was slow to start, but once it got going, has now distributed well over 1 billion vaccines, COVID vaccines. But I think the first thing for us all to think about is, and it goes with one of the other points one of the colleagues put, is actually trying to get countries to prioritize national immunization programs and to use this opportunity of COVID vaccines and the awareness around the importance of vaccination to try and get countries to see this as a huge priority in terms of development and global health. The second one is, I think a very important lesson that we might not have thought about was when we started with COVID vaccines, what happened with WHO is they had an expert committee that I was privileged to be part of. And what started off was the allocation framework was how do you decide with limited numbers of vaccines, which was the case in our region, how do you distribute them? And we've got this, the reason I'm highlighting is we have the same problem now with malaria vaccines, with limited numbers of vaccines. And so what has started to happen globally, which I think is a lesson learned, is that when you do have limited numbers of vaccines, we have something similar for IPV, we have something similar for HPV. How do you actually have a framework as a national immunization framework? How do you decide who would get those vaccines? And the allocation frameworks have been important, not only because they were strongly evidence-based and also iterative, responding continuously to the epidemiology and changing and making new recommendations as time went on, but they were also based on ethical principles. So in terms of when we think about vaccine distribution for national programs, what has now come into the fore is ethical principles. And the stress was made by earlier speakers on very vulnerable communities in conflict areas, refugees, displaced populations. So as we think about vaccine distribution for our national programs, what are the ethical principles that we're going to apply, particularly when we think about zero-dose children? The third one is, and it's come out so loudly, was that we can't wait for a crisis to say we have to strengthen our health systems around immunization programs. This is something that we're going to have to think about continuously and really look at, why are our immunization programs in many countries not achieving the targets that we've set ourselves, including targets that are very meaningful in terms of preventing outbreaks such as measles. So strengthening immunization programs, but also coming out is the issue of vertical programs. One of the comments made with the COVID program has been very verticalized, but we've also heard that comment about polio programs in the past. So how do we integrate the programs in a way that strengthens the routine immunization programs? The third issue that we've really learned, which is core to informing how we use vaccines, and remember, not all vaccines that we use are part of routine childhood programs. Some will be used, for example, cholera, in response to an outbreak. So how do we actually improve the way that we target our vaccines, particularly those that are for outbreak responses? And here, clearly the lesson learned is to strengthen all of the tools that we need for adequate surveillance. This would include strengthening laboratory services. The African CDC has a huge initiative that's already going on for this. But at a country level, many countries have upped their game because of COVID and have really put efforts into their own national programs. And I think the important thing here is that we don't lose this. One of the things we saw with the Ebola in West Africa is that a lot of effort went into immediately and urgently strengthening lab sciences. But when that funding and when that support went away, we lost some of that impetus. This time, for laboratories, we should not lose this. So laboratory services, but also innovation. We've now got the African Pathogen Genomics Initiative, which is in several countries, which is looking at genomics. And you've seen how important it's been in terms of identifying variants. And this region, hats off to us, despite the fact we were punished for it, has been at the forefront of identifying variants as they emerge and sharing the data, which is incredibly important in terms of surveillance. So strengthening the labs comprehensively and keeping going what is there. And this is particularly important in the context of the polio program now being wound down, because quite a lot of laboratory services in our region were getting support from the polio services. So we must think urgently about how we do that. Number 5 is the use of serosurveys. So the Unity program from the WHO has encouraged and collected data from serosurveys to try and start to make global maps of what we know about the COVID pandemic and how it's spreading, including in the African region. And we've seen that this is extremely important. So if we were to say, what have we learned? We've got a lesson that we're grappling with now in our region, and that is that we have much lower vaccine coverage than other regions, but we have high seropositivity because of exposure to infection, much of which has been asymptomatic or minimal symptoms because of the age groups of our populations. So if we're looking at sero surveys, the question will be, are we using that kind of, for what would we use that in terms of routine immunization? How do we monitor what is happening, for example, in measles outbreaks? How do we monitor what is happening and the issue of serosurveys and how we use them into the future is something that the region should give more thought to. And hand in hand with that, we've learned from very strongly from COVID is the use of routine data. So the use of data that's told us about hospital admissions, the severity of hospital admissions, mortality, and tied to laboratory data and tied to vaccine coverage data. This is actually answering questions for us. So one of the questions for our region is, has the disease actually been less severe in our region, which some people would argue, or is that a result of poor serosurveillance? And or is it a result of not being able to collect and use routine data such as hospitalization and mortality data? And that becomes very important for us to understand what is happening with the disease. So the use of routine data and strengthening that. And then I think another lesson that we've learned, and it's a big lesson that we're going to have to really think about in this region, is the fact that the delay in getting vaccines in created a space where a lot of misinformation and disinformation about vaccines was able to creep in, around COVID vaccines specifically. But it also opened a space for people to launch cures and to make profit. But it also meant that by the time the vaccines came in many countries where we got younger populations, people were shrugging their shoulders and saying, we don't want this vaccine. And many countries are grappling now because there's apathy. We don't see that this disease is so severe. But what we do have to now look at much more seriously is the issue of vaccine hesitancy and whether we will see any spillover from what we've seen in response to COVID in terms of national programs. And then just to reinforce what Morena has just said, big lessons learned, a real call from the African Union for local manufacturing in our region. And many countries, many countries in our region now putting up their hands and saying that they want this. But it's not just vaccines we would be needing to manufacture, it's also therapeutics as well. And hand in hand with that, a very big call, which will really help all aspects of vaccine delivery and national programs, is regulatory strengthening. That's already started, but It's really been pronounced through COVID, the need for regulators who can rapidly approve clinical trials and can rapidly approve, even for emergency use, the use of vaccines and other therapeutics. So if we're going to sort of summarize just what I think that we've learned, it would be innovative financing and looking at the financing of our programs and not being complacent to assume that donor funding will always be there and having political priority for financing, strengthening health systems, every aspect of that health system in terms of delivery, as we've heard, the supply chain, the cold chain, etc., the use of surveillance and the use of data, both labs, genomics, and health systems data, the integration of service delivery, addressing vaccine hesitancy, manufacturing, regulatory, and science strengthening. We've got excellent scientists in our region. We need to support them much more. And also to complement that, the importance of implementation science, so that when things are not going as we would like them to, that we actually do what we need to do and ask the right questions so that we can improve service delivery. Thank you very much.
Thank you so much, Helen, for that succinct summary and high-level overview, which is quite brilliant. And I will now hand over to Naveen, who is going to moderate the discussion session. Naveen, please introduce yourself and then carry on. Thank you so much.
Thank you, Benjamin. Can you hear me?
Yes, yes, I can.
Yeah.
Yes, yes, I can.
So thank you so much for this opportunity. I'm a pediatrician and currently president-elect of International Pediatric Association. We have a vaccinology course in India. That is why I came in contact with Benjamin during our workshop on global collaboration. This is something topic which is very close to my heart. So I volunteered that I want to be there. And thanks to Helen again, we served together on Gavi board, where I was representing civil society organizations. So a lot of friends in Africa. I will just say one thing before we start the question answer. When we talk about zero-dose children, so zero-dose children is not only about the children who have not received any vaccination. It is all about their connect with the health system. If they are, you will find zero. What do you mean by zero dose? Because they have not come in the contact with zero dose, and we learned that very early in India in polio eradication. We as somebody talked about polio eradication, we could reach to 99% of population with polio, but we did nothing. We just, what we call in India, 2 drops of life. We delivered the 2 drops of life and we came back without asking how are you or whether you are vaccinated or not. So this is all about primary health care, about universal health coverage, and wherever you will find zero-dose children who have not received any vaccination, you will find other partially immunized children there only. You will find malnutrition there. You will find polio there. You will find stunting there. You will find everything, all the problems there. So it is very, very a thought of a strategy, but let us not just say that we only want to find the zero dose and don't want to do anything. So that's very clear message, because we want all children to be vaccinated, timely vaccinated along all ages. Timeliness of vaccination is also important. So keeping in this mind, let me open this for discussion. There are some questions in chat question and answer. If you 6 are already answered, and if you want to pick up question related to you, you can first go ahead, and then we will we will just go to the people who have raised hand. So panelists, have you read the question and you want to answer some of these questions first? Mary, Helen, or Morena? Okay, you may take. Yes, you want to say something, or we just go to the people who have raised hand. I'm not able to see from here Benjamin and Nana who have raised hands. So can you allow them one by one? Benjamin?
Yes, I see there are some questions from Azabra Awuni, and also from Margarita Corella. Salim, do you want to give them some right to speak so that we can see them? Also to switch on their video and then they can ask questions.
Okay, let me try and do that.
Okay, and I will request all panelists to see the questions in question and answer box, and whenever you are answering other question, you can also take up those questions if you. I know Daniel had left, but any other question you want to answer, please do so.
Maybe as you wait for them, I could ask a question to Helen on spillover of vaccine hesitancy from COVID to other routine immunization services. How do we assess that, Helen? Because it's quite challenging, but it's actually a real thing that it's likely to happen, or it's happening.
Well, I think the first thing I would say is for any one country would be to analyze what the diagnosis of your own vaccine hesitancy community is. First of all, is it significant or not? And unfortunately, what we're hearing anecdotally from many of the countries in our region and from health ministers is that there is reluctance to be vaccinated, and quite a lot of that is to do with complacency, an assumption that this disease isn't as bad as we thought, but it is mixed up with misinformation. What I have found interesting talking to people who are vehement that they're not going to be vaccinated, and is if you ask them why, and then you ask the question, did you get your children vaccinated? Very often the answer is yes. So what I think is the concern is that people who've previously been very willing to and have understood the importance of childhood immunization have now developed a different framework for themselves as adults and adult immunization. Now, I think the question will be, will that filter through? And the only way that we're going to find that out is with really good social science research. And the other thing that we need to be now is very proactive. One of our problems, I think, as an immunization community is we tend to be reactive. We find, oh dear, people are not wanting a vaccine because they don't see the disease as severe. And then we come running behind and say, oh, but it can be, or we need to protect communities, and we're running behind the argument. I think that we should anticipate an argument, and we should then be really, really clear in putting proactive arguments together. But I think it's an area we're going to have to monitor. And I think it's an area where we will need country-specific social science research.
So thank you, Helen. I would like to add Ben, because we are doing a lot of work on this. And you can see in the background, IPA runs a IPA Vaccine Trust course, which is free for everyone. So Helen, you are right. First thing is social listening. You have to listen what's happening in the social media and if possible in the community. Then only you can design your intervention. That's the first thing. Second thing, we have to understand. It started with all of us talking in Gavi board about vaccine hesitancy 5 years back. And then it has spilled over to now everyone, even before Dr. Tedros declared, infodemiology. So it's a spectrum. On the one hand, there is a total vocal vaccine denier. That's not our target. But a large part is, say, vaccine, they are reluctant. They are not actually vocal vaccine denier. And we have to target this group by listening and designing our communication according to that. And a lot of this is happening because of misinformation. And we face that in India. I know I did some of the sessions in Africa, that it is now whatever happens in Africa reach to India or US within hours. So we have to be, there is no one solution, but you have to do your work listening and then design and do the community engagement. And definitely we have to tackle the social media and digital tools to counter this. Ben, you have somebody, there are many raised hands. I don't know why I'm not able to see who has raised hand.
Yeah, if Nena, Chantel, and Salim could manage the people who are raising hands wanting to ask questions, please manage that. Thank you.
Salim, please go ahead.
No, sorry, I was just testing it out. On my side, I don't see anyone currently with a raised hand.
I don't know, because let me see.
I can ask Morena a question as you wait. Morena, thanks for the presentation. My question is on that Africa CTC 2040 vision, where the local supply or production needs to be from 1% to, I think, is it 60%?
Yes.
And I'm wondering whether, if you tie this to the Immunization Agenda 2030, and of course, access to vaccines is a big issue. And we know in some countries, for example, COVID-19 vaccines are being destroyed because we receive them, but we are not able to use all of them in a timely way. Do you think this is going to solve the problem of coverage in terms of increasing local production of vaccines, or there are many other underlying things that need to be addressed together with local production? Over to you.
Yeah, I think a very good question, Benjamin, because I think manufacturers certainly not, firstly, it's not aimed to solve all of the problems that are there. I think it's just but one piece to ensure that the risk of supply is mitigated. So as we know, there are many factors that are affecting, low coverage. One of which is inconsistent or unreliable supply. And vaccines are different. Others have better supply profile. The other one have worse profile. And those moving parts are also very different. Some of them are very difficult to make. Some of them are not attractive for others to make. They may be easy, but they're not attractive because there's no return. Manufacturers are not seeing that return. So I think as one of the causes of, of the contributors to low coverage being inconsistent supply, certainly manufacturer on the continent can play a role. Will it answer all the questions? Absolutely not, because manufacturers themselves undergo challenges. But if we have more than one manufacturer of a product, which is something that UNICEF and WHO have been doing, and Gavi have been doing for a while, to make sure that even if you have, let's say, a large Indian supplier of a vaccine, but that we have more than one, let's take PCV as an example. We've had Pfizer and GSK really been supplying the product for many, and there's been two, and they've been doing fairly okay in terms of risk of supply, but we needed to branch out, which is why Path and Gates supported the likes of Serum to enter the PCV space. So it's really to make sure that there's risk mitigation. And that is as far as routine vaccines are concerned, Benjamin. But I think where now where the exposure comes in, and this is pre-COVID, people were saying, well, there's enough supply of Penta, there's enough supply of PCV, or there's a pipeline. India can do it, Indonesia can do it, South Korea can do it. Why are you even bothering Africa in terms of why you need to have this? But I mean, COVID-19 has exposed that if you can't do it for routine vaccine manufacture, the scale in terms of the risk of supply, I mean, goes so much, goes in multiples when there's a pandemic. And so the lack of what we're seeing at routine, which may not be urgent, but I mean, really just gets exposed. So the two are tied up. So you can't set up just for pandemic. But if you have a strong base for routine, you can play and contribute your part in terms of assisting the coverage, but it helps you to at least upscale at the time that is required, so that you can have pandemic coverage, if I can use that word.
Yes, Greg, go ahead. Please allow him to speak. Yeah, Greg, please go ahead.
Hi, good afternoon. Thanks, Navin. I can't put my video on for some reason, but I just want to shift gear a little bit and maybe address this question to Helen and to Marie. The issue around, the lack of availability of vaccines that have been in use for many years. So, for example, rotavirus and pneumococcal vaccine have been used for close on to 2 decades now. And the problem is that there are still many countries in Africa and in other low middle income countries that have not introduced rotavirus and pneumococcal vaccines. And I just would like to hear the panelists' viewpoint as to what do they think are the sort of main reasons why there has been a reluctance or hesitation in introducing those life-saving vaccines for children in need in low middle income countries, including those in Africa. Thank you.
Well, I could, thank you, Greg. Shall I have a first go? And then I think it's really a very important question. And again, one of the things that COVID taught us is that when you have an emergency, any thought about equitable market shaping goes out the window. But having said that, and that's why I stress this issue of ethics coming more and more into development, even of guidelines these days. Ethics and the word equity is everywhere. So I think that certainly if you look at something like the malaria vaccine, I'll come back to your examples as well, but if you look at the malaria vaccine, because we know already there's a shortage, there's already an allocation framework that's been set up. And part of the idea of an allocation framework is also to start to generate the information that would give, and Morena might want to comment on this, that would give industry the confidence to come into the marketplace. So I think the tools of market shaping and then advanced market commitments, so that and Gavi has, I think, been extremely good at this for the childhood vaccines rather. Those things will help shape and give confidence in the marketplace so that we actually get sufficient generation of vaccines. And those dialogues are happening in my experiences. I've been on more committees now that are looking at, well, we don't have enough vaccines. How do we do this and how do we shape it? And what do we say to the manufacturers? I think there's much more recognition of the importance now of those kinds of dialogues so that we do ensure that we get sufficient manufacturers coming into the marketplace, that we don't get manufacturers coming in and then finding there's a huge surplus in the marketplace, but we get sufficient manufacturers coming in with some sort of guarantee of what does the need look like this year, next year, and in 5 years' time. Because I think part of the problem has, and certainly what I've experienced, and Morena can, perhaps other colleagues can come in, is that the manufacturers themselves have been hesitant to come in, particularly to the low middle income marketplace, whereas they might well have gone into the high income marketplace where the profit profile is a very different conversation. So in terms of what you're saying, Greg, I think these are questions that we should really be raising continuously with WHO, and I know that they're embracing them, but I do think it's about engaging industry very, very proactively with good modeling and good market shaping tools. And then the finance that would also back that up, because countries by themselves might say it's fine for you to model, but we can't do it. And that's where groups like Gavi, MedAccess, these sorts of groups that are trying to support countries, I think would be very important. So I'm not sure that I've completely answered your question, but I think that's a trend that we should encourage.
Mary, you want to add something? Please unmute yourself. Yeah.
Yeah, thank you for the good question. For me, I think that the decision to introduce vaccine depends on different factors at country level. Normally, WHO, when the vaccine can be available, when the clinical trials have been completed, and when the vaccine is pre-qualified for the use, WHO released the positions paper on the use of the vaccine, providing recommendation and some guidance on the use of the vaccine. But the introduction of the decision to introduce the vaccine, it's about the country, is the member state, which sit and analyze the necessity of introducing the vaccine. And they should be analyzing many factors, including the burden of the disease, the capacity of the health sector to manage the vaccine, their cold chain capacity, and all those factors enter into consideration to introduce the vaccine. And it depends, maybe some countries are not seeing the importance of at their level of introducing this vaccine. But also we need to consider, some countries consider the financing issue, operational cost, but we should highlight the need of conducting cost effectiveness study so that they can guide the countries to take a decision. That's what I can say. Sometimes you may find that some Gavi eligible countries are really introducing many vaccines their routine because they have that opportunity of funding. But other countries which are not Gavi funded, they may be reluctant, but also if they consider that the burden of the disease is not really an issue. That's what I can say. It depends on the situation, specific of specific countries. It depends on their decision to introduce. They can introduce or not introduce a vaccine if they feel that they are not able to sustain vaccination. That's what I can say. I'm not sure if I have answered to your question.
Thank you. Thank you. We will take one question from Evan Lebla, and then in meantime, again, I request all panelists to read question in question answer box because we will cover that, and then there are other raised hands. So please, Evan Lebla, please go ahead. You already have speaking right.
Thank you very much. Thanks to all of the presenters for the very insightful presentations. My question is actually directed at Professor Reyes. Sorry if I'm not pronouncing your name right, but if there's any other panelists who think they have some responses, I would really appreciate it. The question has to do with the increased vaccine hesitancy for COVID vaccine that has a spillover effect on routine vaccines. I would like to know what you think are the prospects for integrating COVID vaccines into routine immunization, and how can we overcome the expected challenges we have along those lines. Thank you very much.
Thank you very much. That's a very interesting question. I think just to reiterate that I don't think that we know yet whether what we're seeing as COVID vaccine hesitancy will spill over into childhood. Because as I was saying, just anecdotally, some people seem to have separated childhood benefit from their own personal adults. So I think that's why we need to really sort of study this more. In terms of what you're asking, just remember that at the moment, the majority of countries, this is an adult vaccine. And the benefit, in fact, of the COVID vaccines is optimal in older age groups. Now, however, if you look at IA 2030 and Gavi 5.0, everyone is now talking about a whole life cycle approach to vaccination. And it might be that with time, we want to look, for example, at older age groups and say, should we be pushing influenza vaccines as well? Are there other vaccines that currently wouldn't be affordable, but there might well be other vaccines for other diseases that might be appropriate, pneumococcal vaccine, for example, in the elderly. So the question would be, where would you put a COVID vaccine that currently is really being stressed for that older age and is mostly being given for adults, and probably benefit risk for a healthy child at the moment with the variants that we've got is much less once you go down into that much younger age group. So if we're thinking routine immunization, under 5 immunization, that's one thing. If we start to think about HPV vaccination, adolescent vaccination, then it's a different discussion. But the question would be, what would be an appropriate vaccine for that age group? And then I think it raises the question about, if we're serious about a life cycle approach, should we be starting to think about older people who are at more risk, particularly respiratory infections, and think about what we should be offering them? Thank you.
Thank you. So I would like to add, you are talking about a spillover of vaccine hesitancy to routine immunization. But please also remember that there was never such a discussion on vaccine. We never heard the word vaccine eagerness. So whatever is the vaccine hesitancy is prevalent. But I know when in India we had some problem in middle age group. As soon as we opened for the younger adolescent, and younger age group, we had so much eagerness. There were so this is how. I think we, by and large, we have managed, leave aside the supply, but we have managed the COVID vaccination well. In terms of with initial hiccups, now we are able to communicate what vaccination, how vaccination can help in controlling pandemic, at least serious disease deaths and hospitalization. And as I used to say in beginning of when we started COVID vaccination, that this is the time when if you do it well, the immunization, whatever we are struggling with immunization, will be will be helpful. But if you do it badly, but I think we have done well, and we have learned so many things: how to handle misinformation, how to create demand, and how to, as Helen said, how to immunize across the life course. India never had accept anything except the childhood immunization, and now we are confident that we can give HPV vaccine, we can give other vaccine at a different age group. I think I will take some questions from the chat question answer, and then we will take the live question. So yeah, so question is what from Fatumata. Hello, what are your experience in implementing COVID-19 vaccination for children in terms of SAE and the reaction of the community toward their children taking the second dose? Who wants to take this question? Helen? Can you see the question? Open, you can go to
I
open.
can't see that.
Okay, I will read again. What is your experience in implementing the COVID-19 vaccination for children in terms of SAE and the reaction of the community towards their children taking the second dose?
Well, I'm going to be cheeky here. I'll say something, but I'm going to also invite Greg Hussey to comment, because he's currently in South Africa developing a guideline for COVID vaccine immunization, and I'm sure he would have some views on this. I mean, I think there was one paper from the UK that said that people's tolerance of rare side effects in children and adolescents is much less than it is for themselves. And so the benefit, if you looked at, say, if we often argue, if you take something like myocarditis, we often argue that that is much more common if you get the disease versus the vaccine. But this one study I saw suggested that people would want to see a sort of 6-to-1 benefit, i.e. that you would have to have at least 6 times the rate of that in the disease for them to tolerate even a rare adverse event of 1. So people's expectations of protection, it is not necessarily based on a sort of logical statistic. It's actually, there's quite an emotional thing if you think there's a risk of a rare side effect, and particularly for children. So far, certainly in most of the African countries, and perhaps from India, there might be different experiences. We haven't gone to younger children yet. And there are very few vaccines that have so far been approved for younger children. And indeed, one of the discussions in terms of vaccine development is whether there's a case as we look forward for perhaps novel and new COVID vaccines, or coronavirus vaccines rather, whether we should be looking at inactivated vaccines that are well known for use in children and have a good safety profile. So at the moment, there's not a lot of experience, but I think that we could expect that there would be this quite a level of sensitivity, even about a very rare side effect. But we don't have a lot of experience, and certainly not in this region. But I would invite Greg, because he's been looking into this in some detail.
Greg, Professor Hussey, can you answer?
Yes, thanks, Navin, and thanks, Helen. I think the first point to make, as Helen has said, that there are no countries in Africa, certainly, that have introduced COVID vaccines for 5 to 11-year-olds. There are 1 or 2 countries in the Middle East, 1 or 2 countries in Central South America that are thinking about introducing it, but certainly in Africa, there are no countries that have introduced vaccine for 5 to 11-year-olds. There are a few countries that have recommended vaccines for children, adolescents, 12 to 17 years of age. South Africa was one of the first to introduce the vaccine a few months ago. Our experience has been reasonably good. The problem is coverage is not optimal. We currently have probably only immunized, I would think, around about 30–40% of that cohort of 12 to 17-year-olds. We are not aware of any significant adverse events that have occurred in those children. I think the issue really relates to the problem with myocarditis in the adolescent young adults, and then also the syndrome of inflammatory disease that have occurred following COVID infection. So I think the coverage in our country has been low because I think there's a sort of COVID fatigue setting in. The parents who've taken their children for vaccine are obviously confident that the vaccines will work, that they're safe, and so forth. And the fact that we haven't had any significant adverse events in the cohort vaccinated to date is in fact very, very good. So that's where we are at the moment. We're considering introducing COVID vaccines for 5 to 11-year-olds, but more in the context of the children who are significantly immunocompromised, rather than for all children 5 to 11-year-olds, because the risk of COVID disease is not that great compared to older children and adults in that age group. And we feel that we need to up our game with respect to vaccinating adolescents and then also the older age group. I mean, our coverage, for example, completely vaccinated 60-year-olds is just over 60%. So, there's a large cohort of people at significant risk of COVID who have not been vaccinated. And, we're sitting on the cusp of a new wave and we need to protect the unvaccinated. And there's been a debate around, should we, shouldn't we be, stepping down to the younger age group. People feel that we should be focusing on the at-risk populations, especially the persons over the age of 60 years, and those at more significant risk, the people who have HIV, AIDS, the diabetics, other individuals who are immunocompromised. And even in that population, overall, the coverage is low. So those are just a few comments.
So
thank you, Navin.
Yeah, thank you, Professor Hussey. I will just tell our experience from India that when we started COVID vaccination for first, as Susan said, that we started with the framework, and that's very priority framework is very important. Once we had a very high coverage in the susceptible population, we gradually decreased the age, and when we started for the 15 plus, there was very enthusiastic response, and we decided to use inactivated vaccine, Covaxin, very few side effects and very high coverage. And now it has been extended to 12 and 15, 12 to 15, and today, yesterday only, the government has given emergency use authorization to Corbevax, which is Peter Hottage vaccine, a very known technology for 5 to 11. But we should go slow. And for any country, it is very important to monitor your epidemiology, what's happening in children. Same thing may not happen. Whatever happened in West, it never happened in India. Children were getting infected. And again, what Helen said, zero survey is very, very important. We thought children are not getting infected, but when we did the zero survey, it was as equal to what adults were getting, but there were not much hospitalization. So it all depends on priorities and your local epidemiology. There is one more, there were few comments on Angola, which I think more comments than question, but there is a two question which we will take and then go for the live question. How can Africa country balance between funding immunization in the context of other health and non-health emergency, given their low income status? And maybe it is related question, or at least creating an enabling environment for pharma companies to penetrate our system. Anybody? Morena, or you want to answer? What do you unmute yourself?
Yeah. Oh, sorry. I mean, I can take a stab. I mean, these are public health matters. So I think there will always be need. I mean, these needs or competing priorities are not going to go away. You're not going to find a situation where everything works perfectly. And understanding that there's some things that really we can plan for and try and prevent in time, and there's some things that are unplanned for. I mean, the whole the pandemic is one thing. I mean, South Africa is now dealing with a crisis in KZN and in Durban of floods, and so we have all sorts of issues that are at play. I mean, it also goes back to ultimately, political decisions that get made. If there is, if countries prioritize things that are a foundation. Now, you can't plan for all force majeure elements, but there's some things that are really basics, that are public health issues that are there, like infrastructure, clinics, hospitals that can be budgeted over time. Immunization can be budgeted over time. So as much as it feels like it's competing with others, but like anything that if it's allocated continuously, there's line of sight about what's going to happen in the next 5 to 10 years, it makes it easier. And again, I'm not a government, but I believe that it makes it easier for even donors or even when governments go for loans, for them to say, okay, what are the programs that are working and what is your long-term objective? So that when countries go to the IMF or to the World Bank and others and are asking for development finance and all of that, that some of the basics the countries have gotten right. For me, it's important that it starts at the country level and the country says, look, I'm going to allocate whatever percentage to healthcare. Of that percentage, I'm going to allocate so much to vaccines. And yes, I can't cover all my vaccines, but this is what I'm going to do, and I'm going to get the international community to support me. I think some of those basic principles are probably needed to go back, that countries need to go back to some of the fundamentals. I mean, Gavi has been extremely frustrated, I believe, in terms of some of the graduation plans that were supposed to be there previously. Now, some of them, the countries, there was oil crisis and all of that, and so they couldn't meet their graduation targets, But it's some of those things that I think, we really need to go back to the drawing board as countries, budget, have them in place, and then you can have the confidence of external help that will come through. But external help must come in the context of you're already looking out for yourself, rather than just relying or outsourcing the help, if I can put it that way, to donors and others. Thanks, Naveen.
Yeah. Anyone wants to comment? Or we will go to Emily Tangi. You are already unmuted. Please go ahead and ask your question.
Thank you for this very nice discussion. My question goes specifically to Dr. Morena. You kind of gave the trajectory, of vaccine manufacturing, and it feels, or it looks overwhelming, considering the political and economic situation that most low and middle income countries are facing. So I just want to ask, what can we be doing practically at this moment? Yeah, we don't just want to give up, but what steps can we take practically, to work towards that? Even if our generation doesn't succeed together, but those who come after can build on what we already have. So what structures can we start with? Yeah, in terms of implementation, and not just to be overwhelmed with the big picture. Thank you.
Yeah. And Emily, I assume you're talking in the context of vaccine manufacture, huh?
Yes.
Yeah. So, okay, so 100%. So let me somewhat contradict what I was saying. So so in my presentation, I was showing the enormity of what it gets in terms of establishing end-to-end manufacture. Okay, that it's not easy. It takes time and it takes a lot of money and effort. Okay, so, and yes, that can sound overwhelming and sound somewhat unachievable. But you don't have to start with everything. You have, so other countries may start on the research side, some other may start on the development side. Our company started by importing vaccines, just purely importing vaccines, okay? It allows you to have a network to know who's in the East and the South and the West. We then started going into packaging when we could afford to, and then started going elsewhere. So firstly, I don't think because it is a sector that has high barriers to entry, regardless of whether it's not an African specific thing. It's whether you're in the East and the West, doesn't really matter. This is a biotech, it has high barriers to entry. However, it does not mean that you cannot start. And I think what we then need to look at is the settings that are in your country in terms of where is it best that I can start. If, let's say, there's more research funding going through, and you'd rather start from the research side and then go upstream, please take on and tackle that. If that part of the value chain is thin, you can look at more of the downstream side and say, how am I going to play an active role in that? What I'm quite emphatic about, though, is that vaccine manufacture should probably still remain in the domain of private sector. Now, I know that sometimes the private sector is obviously just associated with dollars and all of those things. However, this is really based on history. All the successful vaccine manufacturers globally, regardless of whether you're in the developed world or in the developing world, the most successful have been private sector owned and led. Even in industrial or in developed countries, where there were, I don't think there are any more left, but when there were public sector vaccine manufacturers, they have not succeeded as much as private sector institutions, which essentially means that they need agility, they need innovation, and private sector can then go and raise money. So to some extent, private sector does not then have to look at government and say, government, please give me money to build. All it needs is an enabling environment and say, look, I'll go for external funding. But government, I need you to support me so that when I bring funders, that the ecosystem is well enough for me to do that. And I think that is something that needs to be well understood. But I mean, and I know there are very many African vaccine manufacturers that are state-owned. But for me, if I had to choose a model, I think it should be private sector-led, but working very closely with government in terms of government facilitating the infrastructure that needs to be there. But yes, as much as it seems enormous, it's not impossible. You know, if our company can do it, certainly anybody can do it. But just know what you're getting yourself into and learn lessons and reach out, you know, to many others. You know, just like anybody doing a PhD study, you go from the left to the east, and then you come up with your document. So, like anything in a business case, you do your research, you see where you want to start. It's certainly possible, or that much I can tell you. Thank you.
Thank you. So I will have this last question if anyone wants to answer, and then hand over to Benjamin. So you see, this is from Asrat Bile. We all understand so many efforts made on immunization programs since 1974, but still in about 58% of the countries implementing immunization program stalled or going back. What could be done, especially in these areas? I know you have covered this many times, but a very brief answer, if you want to give, Professor Helen.
So I think it's a really good question. And what we find in bigger countries is that it's not just one size fits all, that if you look at a country like Nigeria, you'll get high coverage in one state and very low coverage in another state. So I think the first thing one needs to do is to have that diagnosis. And there's a window of real opportunity now because of the focus on vaccines because of COVID. So this is a really good time to go back to countries and to ministries and to say, you're not getting the coverage up. What is the problem? So the first thing is you need to know what is it? Is it that you've got remote rural areas? Is it that you've got rapid urbanization? Is it that you've got fragile state, migrant communities? Because each of those solutions would then be different for that. But I think the other thing that we probably should think a bit more about is in different contexts, are there incentives that could be offered that would encourage people to come forward? Sort of carrots and sticks, what would they look like? You know, school entry, being fully immunized, you know, those kinds of things. I think that we need to really seriously think about that because we're talking about children's lives and well-being. The second thing is that we must use science to be more creative. We're kind of stuck with the idea that this is the way that vaccine is, with a needle and a syringe and a cold chain and this. So we are already looking at more stable vaccines that can survive longer outside a cold chain. We should be looking at microneedle patches. We should be looking at intranasal vaccines. Those not only are easier to administer, but you can use them in conflict zones. You can use them in difficult to reach populations, and you can train non-highly qualified nurses to administer them. So we haven't over the years thought enough about alternative technologies. And then similarly, just a breakthrough that will make a huge difference. We need to continuously ask about schedules. So HPV vaccines, we've got terrible coverage in our region, but we've just now got sufficient data to give us confidence, and SAGE has recommended this, that we can use a single dose. Just think how that will revolutionize access to an HPV vaccine. So I think all of these questions, we tend to take things for granted that they are like that. This is how, and I think we need to have a sort of rethinking about the science, including the science of how do we improve the technology for access. Thank you.
Thank you, Helen. And you rightly said, and I think this is the best time, whatever maybe we suffered from COVID, but also a best time for immunization when everybody is talking about immunization. And we used to talk about value of vaccination, but pandemic has already taught us value of vaccination, which we struggled for a long time. So taking all those steps what Dr. Helen Rees suggested, I think we can definitely go there. And let me tell you again that after 70–80%, it becomes very difficult to increase the coverage when you have to have a specific strategy, and like we are doing in India for reaching, say campaign mode, reaching to those children and trying to find out what's happening there. So I think we are, as a convener of vaccinology courses, we will work together and see that we create more and more vaccine champions everywhere. And pandemic has taught us that nobody is safe till everybody is safe. So we work work together and see what we can do to achieve those targets. Thanks to all the speakers, and thank you, Benjamin. I hand over back to you.
Thank you so much to our panelists and also to our moderator, Naveen. Appreciate very much, and also to the participant. So we come to the end of this first webinar. And just to also acknowledge that Pfizer has given us an unconditional grant. They are not involved in the topics that are being chosen for this webinar series, but just to acknowledge their support. And finally, to say thank you to our team, Dr. Nena, Dr. Edina, Salim, and Chantel. Thank you so much for supporting this. And the next webinar is going to be on the 29th of April 2022. You can be able to find the registration details on our website. And with that, I thank you again very, very much, and wish you a very happy weekend. Thank you, and bye, everyone.
Thank you. Bye.
All right.